Sophie Wheelock, Policy and Research Associate here at the New York State Health Foundation. Welcome to today's installment of our Practically Speaking webinar series, where we share actionable ideas to better serve New Yorkers during the COVID-19 pandemic. Today, we will talk about supporting expectant and new parents through home visiting programs. A key issue during more normal times, support services for pregnant and new parents are more important than ever during the current pandemic, and all the more challenging to deliver. Early in the pandemic, pregnant New Yorkers had to navigate the rapidly changing environment of delivery and support services. As New York remained on pause throughout the spring, home visiting programs rose to the occasion to provide critical education, tools, and referrals for low-income families to support and empower them as they became parents. With us today is Rachel Schwartz, Senior Director of Maternal Child Health at Public Health Solutions. We are also joined by Poulette Brewster, Director of Queen's Healthy Start at Public Health Solutions. Public Health Solutions has long been a leader in home visiting programs and has innovatively adapted these programs to continue to support New Yorkers remotely during the pandemic. Before I pass things over to Rachel and Poulette, I want to note a few housekeeping items. This webinar is being recorded, and a recap link, email and link to the recording slides will be circulated afterwards over email. Video and audio are disabled for attendees, so please submit your questions and comments through the chat box throughout the event. After the presentation, I'll read aloud questions from the chat box for the panelists to answer. So without further ado, we will now hear from Rachel and Poulette.
Good morning. Thank you everyone for being here. I am just going to share my screen briefly. Okay, so as Sophie mentioned, we're going to be talking about supporting expectant and new parents during COVID-19 and hopefully providing some actionable ideas based off of what we've done, and also talk about how we've really expanded our body of work in unexpected ways during the pandemic. Today, Poulette and I are here speaking on behalf of our Maternal Child Health Unit at Public Health Solutions. We're made up of nearly 60 incredibly dedicated people who, while we were all living through this pandemic personally, also kind of really stepped up professionally in such incredible ways to support the families and individuals that we work with. Also want to note that we've been supported by an incredible organization that we feel has really gone above and beyond in response to the pandemic and has provided us with this strong foundation to be able to do the work that we do. Hold on. Okay. So briefly about Public Health Solutions, we're the largest public health nonprofit in New York City and work to advance health equity and help families achieve optimal health and build pathways to reach their potential. So our three-pronged approach really to improving health outcomes focuses on direct community work. We provide neighborhood-based health services throughout the 5 boroughs. We have a large contract and management services arm that works with many community-based organizations throughout the city to support them with infrastructure and fiscal management. And we have a growing healthcare community partnerships component that is overarching to all of our work to really look at bridging the gaps between healthcare and community, both to reduce reliance on the healthcare system, but to advance health equity specifically as well. So our vision is a city where New Yorkers have a fair and just opportunity to be healthy. A large piece of that is working across maternal child health systems and working to really build systems of care, and then providing individual and family health and well-being services are all direct drivers of equity as well. I think a lot of people are familiar with the social determinants of health graphics like this that really show that up to 80% of an individual's health outcomes are determined not by clinical care, but everything else, the places where we live, work, breathe, and sleep, and all of that. And when thinking about it, it's really driven our COVID-19 response to make sure that we're listening to the families that we work with, hearing what they need, and then working very diligently on the back end to try to meet those basic needs, to really focus in on all of these icons that you see around the edge of the graphic here. PHS works with more than 200,000 New Yorkers. So within our neighborhood health division, we provide health insurance enrollment. We operate the largest network of WIC centers in New York State, Maternal Child Health, which you'll hear about today, We do food assistance through SNAP enrollment, operate 2 sexual and reproductive health centers in Brooklyn, provide HIV/AIDS community-based outreach and support for organizations, and operate New York City smoke-free, NYC smoke-free. So maternal child health at Public Health Solutions. In New York City, just to pause, and I do want to give a shout out to all of the home visiting programs across New York State and in New York City. There's over 90 individual programs operated by something like 50 agencies who have been doing an incredible amount of work, always do, and really have stepped up during the pandemic. Within PHS, we have 7 individual programs that represent 5 models across 4 sites in Queens, Brooklyn, and Staten Island. In addition to home visiting, we facilitate and provide support to 2 social workers that facilitate virtual Remembering You, Remembering Us groups. So those have always been virtual bereavement support groups for anyone who's experienced a reproductive loss, and they're available in English and Spanish. And we're the Queens Cribs for Kids distributor, so provide free cribs and safe sleep education in Queens at our Corona and Jamaica sites. So for those who are not from what we call the world of home visiting, just wanted to touch briefly on why it's so amazing and really so encompassing and really perfectly suited to be in response to COVID-19. And really that is because it's based on relationships. And so I can attest to early this morning, parenting is not easy, but home visiting is here to help. And so across several different program models, some of which are evidence-based, others which are evidence-informed, there's really a large host. This is just a sampling of 2 generational outcomes that arise from home visiting. So some examples of those are strengthened parent-child interaction and developing positive parenting practices to help parents be the parents that they want to be, provide them with the tools to do that. Safer and healthier pregnancies. And so some program models have very clear outcomes related to reduced rates of preterm birth and low birth weight. Knowing your rights. This is kind of always prevalent in home visiting in terms of making sure individuals and families know what their rights are when encountering the healthcare system, especially moving through pregnancy. And that's really come up during COVID as well, to make sure that, you know, as information was rapidly changing, I think a lot of folks know in New York, there was quick rules around not allowing partners in during labor and delivery, and then that changed. And so we did a fair amount of training for our staff to make sure they knew, kind of had up-to-date information and could provide that up-to-date information to families as well. Parenting education, so general health education really is one of the cornerstones of home visiting, in connection to social, emotional, and behavioral health support as well. A lot of reproductive life planning, brain development as well, so teaching developmental activities to increase early literacy and child school readiness. And then the other cornerstone really that home visiting has always done is assessing individuals and families for needs and interests and helping them connect to any service really in the community. So briefly, these are some of the main models. These are the main models that we operate at Public Health Solutions. There are more. We operate 2 Healthy Families New York programs, 1 in Queens and 1 in Brooklyn. 2 nurse family partnership programs, 1 in Queens and 1 in Staten Island. Queens Healthy Start that you'll hear from Poulette about in a moment. The Queens Maternal Infant Community Health Collaborative, and our newest pediatric community health worker program. So we don't have time to go into those models today, but wanted to give kind of an overview. And really, we like this image because it shows kind of a network of support. No one program can do everything, but when you have a network of programs working collaboratively, you can really kind of span this age range of pregnancy through early childhood development. So I'm going to pass it on to Paulette Brewster now, the Director of Queens Healthy Start Partnership.
Hello, everyone. Thank you for having us. I am going to talk about the Queens Healthy Start Partnership, and as Rachel mentioned, this wonderful network of home visiting programs that we have at Public Health Solutions. We also have created a wonderful partnership in Queens, Queens Healthy Start. So the Queens Healthy Start is a collaboration between Public Health Solutions, the Department of Health operated Nurse Family Partnership, Community Healthcare Network, which is a local federally qualified health center, Sheltering Arms Healthy Families Jamaica, and Jamaica Hospital Medical Center. So Healthy Start is a federally funded initiative to combat infant mortality. And any community that qualifies for Healthy Start has to show that they have 1.5 times more the infant mortality rate than the national average. So the national average is 4.2 right now. So we demonstrated that we actually, for our service area, have an infant mortality rate for Black African-American babies of 10.1. And a newest part of our service area is actually Long Island City, where they have an infant mortality rate of 32.7 for Black African-American babies for the 3 years that we showed for our needs assessment. So at Healthy Start, we provide prenatal care and education, food support, breastfeeding support, home visiting services, emotional and mental health support, job training, adult education, referrals, and we also offer a fatherhood component, which is very new to this second Healthy Start cycle for us. Next slide. So as I mentioned before, we are a partnership, so everyone has a role to play in this Healthy Start work. Together, we are charged to serve 700 individuals in our service area, and of those 700 individuals, 100 have to be fathers who are connected to our Healthy Start mom or Healthy Start baby. So each of us plays a role. Public Health Solutions, we operate the community, the centralized intake and referral system for this partnership, which we call it a no wrong door approach to maternal child health needs and services. So any provider, any family can come through coordinated intake and referral system and be connected to the appropriate home visiting service, WIC, SNAP, anything that they would need for their family. We also have 2 family support coordinators through our Public Health Solutions portion, and we also operate the fatherhood coordinator portion and also a community action network, which I'll talk more a little later. Jamaica Hospital, they are expanding their centering pregnancy program in the St. Albans Clinic, which is one of the neighborhoods that we service through Healthy Start. The Nurse Family Partnership, they are actually our non-paid partner. So they're at the table with us because they want to be at the table with us. And we also provide a great amount of referrals through our CINR to the NFP program. Our Community Healthcare Network partner, we support 1 prenatal coordinator, which actually provides services in 3 locations, 3 clinics here in Queens, 1 in Long Island City, Sutphin Boulevard, and then 1 in Jamaica. They screen all of their prenatal patients for home visiting services at the 3 clinic sites. Our Sheltering Arms partner, we support 1 family support specialist, which follows the Healthy Families model, and we also support 2 maternal child health specialists, which utilizes the Healthy Families curriculum, but they don't strictly follow the Healthy Families model. And they also provide prenatal groups and support to those who are not enrolled in their program. As I mentioned before, we also implement a community action network. All Healthy Start programs are required to implement this entity in their service area, which creates their own agenda separate from the Healthy Start agenda. Our community action network is facilitated and led by our coordinator. And when looking for a coordinator for any community action network, you need someone who has experience with organizing, who lives in the community and really knows the community, and who is able to bring energy to this work that can sometimes be a bit long, challenging, and dry. We utilize a collective impact framework where you need a strong backbone support, which Public Health Solutions is the backbone organization of this CAN. You need a shared agenda, shared measurements, and reinforcing activities. Our CAN consists of providers from the community, residents, and also participants of home visiting services. The CAN decides their area of focus, and sometimes the world decides our area of focus. With COVID, it has shifted our topic of interest, and we have dove into providing education and support to the community on COVID prevention. And of course, now our meetings are virtual. So about mid-August, we were granted the Test and Trace Initiative grant through Health and Hospital Corporation to put forth COVID-Free Queens, which is a collaboration of various community-based organizations around Queens. And we are playing our part here in Jamaica to distribute PPE, education, and to ensure that people know where they can get tested and know even they can get tested no matter their status and where the appropriate locations are to get tested. So this is a photo of one of our distribution events in one of the public houses in Jamaica, Queens.
So to focus in a little bit more on really the impact of COVID-19 and how we've responded, we're going to move into talking about that now. And so this is another example. This is following a recent baby shower that we did in partnership with Empire Blue Cross Blue Shield, where the baby shower itself was virtual, and then families were able to come by very briefly and pick up kind of baby shower support gifts. When thinking about really, I think what's helped us to be so successful and responsive during COVID-19, it's really focused on three things. One, as we mentioned, is our incredibly dedicated staff who have absolutely had boots on the ground. We very quickly, thanks to our amazing team, kind of developed safety protocols, made sure to prioritize to put on our own safety masks first, and make sure that our teams were safe, but then also as we stabilized to make sure that we were really there providing support to families in a safe way. Additionally, the strong infrastructure at Public Health Solutions really helped us to move very nimbly. PHS just so happened in February to transition to a new telephone system, which come March helped us to be able to, you know, as of one given day, March 16th, transition 100% of our home visiting services to virtual telehealth-based services. The other one that we really wanted to shout out and lift up today is our partnerships. And so while we have some new partnerships because of COVID, where we've been so successful is because of our longstanding partnerships. And so it's really building off of what was already in place and people coming together in response to hearing from the communities and families we serve to be able to respond. So briefly, this is just a look at our transition to virtual services. I know this is a lot, but if you look at the image on the left, this shows the dark blue are phone-based services, the light blue are in-person services, and the orange are video-based services. And so the red vertical line is the week of March 16th when we transitioned, and you can see, you know, the majority of our services, always home visiting, are in person. And then following that week, we had a quick transition to primarily phone-based, and one of the big kind of struggles and I think success stories for us that we're still working on is increasing the percentage of video-based visits. And so there's a lot of different engagement, of course, that happens when we can see each other in terms of checking in on parent-child stability, child welfare, and really connecting with families. And so as you can see, a growth in orange, we've had increasing success in connecting and ensuring families around technology, working with families around telehealth to increase our percentage of video-based visits. Briefly, you can also see on the right-hand side just how our general volume went up, and this is just the number of weekly visits across our entire network of home visiting programs. So you can see, of course, you know, a general trend upward starting in March. And we started tracking new visits a little bit later in May, but of course, one of the hardest things to do virtually is outreach. And so it was really important to us to be looking at what was our retention with families, but also how were we reaching new families that we weren't already working with. And so we've been tracking that as well. These are some examples. So again, just to lift up our partnerships, none of this would be possible without all of our partners. So specific, very close partners of ours: Empire Blue Cross Blue Shield, Good Plus Foundation, Baby to Baby. I won't walk through it, but you can see we've done a large host of distributions. There's probably been at least 20 specific distribution days across our programs and many more, helping keep families safe, providing them with the basic needs right now. We've applied, in addition to these actual tangible items, of course, what most people need most, and what we're hearing is people need money to, you know, make decisions around covering their own basic needs. And So we applied for several grants and to date have provided more than $50,000 in direct cash support to families in terms of accessing food and other items. Kind of sticking with the theme of building off of partnerships, this is 2 weeks ago outside of the Jackson Heights Family Health Center in Jackson Heights, Queens. New York Presbyterian and New York Presbyterian Queens have been incredibly close working partners of ours for several years now. And so because of that longstanding partnership, they reached out to us with a new opportunity earlier this spring. And through a partnership with the West Side Campaign Against Hunger, we've been able to launch the Queens Mobile Market. So this model happens every 2 weeks to date. This incredible team has distributed more than 10,000 pounds of food, fresh fruits and vegetables, non-perishable items, in addition to providing diapers, PPE, and COVID-19 education. And so you can see some of the boxes in the back. The way this program works very briefly is when families bring their children in for their well child check. So for the newborn visit, 1 month and 4 month visits, and now we've expanded to prenatal visits. Families are screened for food insecurity, and if they screen positive for food insecurity, they're offered enrollment into this free year-long intensive cohort. Additionally, another new initiative that we're very proud of, and again, this is building on partnership and infrastructure. So as many people are aware, during the surge in New York City, discharge following birth was really ramped up very quickly. And so people were discharged about 50% quicker than they normally would be. So of course, one of the huge challenges is families receiving breastfeeding support. So through a partnership with Bronx Healthy Start Partnership, Community Health Center of Richmond on Staten Island, and Northern Manhattan Perinatal Partnership, we came together, identified this as a need, and put together a network of 100% virtually of volunteer certified lactation counselors. Currently have about 20 volunteers that support this work. And people can call in and within half an hour be connected through video, as we're doing right now, with a certified lactation counselor. Things that we normally do in person, which are a host and plethora of support groups that many home visiting programs across the city and state provide, we've pretty successfully transitioned those to virtual environments, and it's actually increased participation in really interesting ways because it reduces, the need to travel. And so while optimally we would all be sitting in person together with babies and talking, that's not possible. And so virtual groups have happened and continue to happen very regularly. So there's a host of those. I won't talk through them right now, but we're continuing to do more and more virtual groups and really looking to expand these offerings.
So there has been a great impact, as we all know, on our family and our staff. For our families, loss of employment, no longer, being able to afford necessities was something that we had to quickly activate and try to fill that gap early on. One of the things that families had a hard time finding early on were diapers and wipes, water, and access to food. So we did manage to get ourselves together to fill in that gap pretty quickly. Also, this has been a difficult time for our staff, adapting to new technology, working from home. They themselves being parents and having to remote learn and remote school with their kids has been pretty difficult to balance. Accommodating staff who are not necessarily comfortable with working from home and having to decide, well, maybe you do need to go into the office 1 day a week to balance out. We've had to do contactless distribution. So if a person comes to the office to pick something up, facilitating that contact and that distribution. We've had to do drop-offs to people's homes who don't feel safe coming out into the community. And that's another thing that we've had to navigate is the misinformation of COVID that does exist for our families, and really informing them and educating them on, yes, you can come out as long as you're wearing appropriate PPE has been key for us. Another thing that we've had to navigate is a decrease in well child visits and families who are seeking vaccinations for their children because they are fearful of what's out there and the unknown.
So that pretty much wraps up for us our base presentation. This is just a snapshot of some of the families that we work with, but happy to speak through any questions right now.
Thank you so much, both Rachel and Paulette. That was an incredibly informative presentation, and I'm impressed that not only you've been able to adapt your services during COVID, but also expand your services. I don't know when you are fitting in the time to sleep. And it was particularly interesting too, how kind of this combination of your dedicated staff, your partnership model, and then the strong organizational infrastructure that you have has really enabled you to continue your services and expand them. So I'll be looking at questions in the chat box, so please encourage all attendees to submit a question if you're interested in posing a question to Rachel and Paulette. I'll start off with a few myself. I think your presentation really shows that necessity is the mother of invention. So I would be curious to hear if any of these changes that you've adapted during the pandemic have been surprisingly successful, and if you're planning to permanently adopt any of them because you found, for example, that those changes have helped increase access and that could work during non-COVID times.
So definitely for Queen's Healthy Start, we would love to continue virtual visits. It's not something that we offered prior to COVID. We did either home visits or in the office visits. But, you know, our retention has improved, our capacity, we're at capacity. So definitely continuing some form of virtual visits, and also offering our parenting and anger management classes virtually has increased attendance.
And other options, other things that we're definitely sticking with is the warm line, for example, mentioned, but it's really, and we didn't present data on it, but looking at just participation, we always do a large number of support groups throughout, across the reproductive life course, and participation in those groups has really increased. And so things like the warm line and some virtual groups, we definitely plan on continuing. So that's another example.
Great. And recently, the foundation has been doing some more research related to severe maternal morbidity or outcomes in labor and delivery that cause short and long-term harm to a woman's health. I'd be curious to hear how you think that home visiting programs can help play a role in detecting pregnancy or postpartum complications that could potentially cause severe maternal morbidity.
Definitely. So using Queen's Healthy Start as a model, starting with our coordinated intake and referral system, everything is about screening and everything is about connection. So screening early on, you do see what are the risks. All the education and empowerment that we give our clients allows them to walk into their doctor's office and ask questions that they previously wouldn't ask, know things that they previously wouldn't know. Through our Moms Club, we talk about signs and symptoms of labor and delivery, and I could speak to one instance where our facilitator talked about the mucus plug and, when that comes out, what that looks like. And mom experienced that and was able to know quickly what that was. So just the level of education and empowerment that we give our clients and that connection. Our partnerships are very strong. With Jamaica Hospital, we had a client experiencing a situation postpartum, and we were able to make that connection with the hospital quickly. So it does facilitate a smoother pathway for our participants.
And there's certain, just to lift up one program in particular, model, the nurse family partnership model, which is with bachelor's prepared nurses. And so they do a higher level of clinical monitoring, checking blood pressure in the prenatal period, checking baby's weights and mom's well-being throughout. And so depending on the program model, I think how adverse birth outcomes are prevented looks a little bit different. But really the foundation, I think, is having a trusted person. And so if somebody feels like they're not being listened to by their provider, they know that their home visitor is there in support. Many of our home visiting programs will connect with the provider. I'll give one other quick example, actually for a COVID positive mom postpartum that we had in the past several months, and she was having a lot of symptoms and having very intense leg pain. And so, it seemed like she had a blood clot. She had been discharged from the hospital for that issue 3 times and told that no, she's fine. And so kind of by having these partnerships, the home visitor lifted this up. we used our network and longstanding partnerships to call the director of nursing and then have a physician call the house within the next 15 minutes and then take further steps with that family. And so it's really having the basis of relationships and having someone that families can reach out to makes a world of difference.
Great. Now taking a couple of questions from our chat box. We do have a question about what platform you all have used for your virtual calls and meetings that helps you accommodate client privacy, but also be accessible for folks.
Sure. So this has been wonderful and challenging, I will say. So we use RingCentral, which is a Zoom-based platform, and it looks exactly like what we're doing right now. It's been really wonderful. It's what we use the warm line with as well. That being said, it was not created for telehealth by any means. And so it really presents a host of challenges for families that are more resource constrained in walking through kind of downloading the app on their phones and all of those things. So we currently use RingCentral, which is Zoom-based, and are exploring other ones to really try to reduce as many barriers as possible to interaction, but that's what we're currently using.
And a couple of follow-up questions for that as well. Some folks are curious if you have data on how many moms use smartphones, particularly to connect, and if you have data on the share of people that are using video visits as opposed to just voice services.
Sure, I can just super quickly, let's see how nimble I am. Just go back to this slide showing, so these orange are the video visits, and then the blue are phone-based visits. And so, you know, starting off with around 20% in March, we're able to connect or chose to connect. Of course, some people aren't going to prefer video, and we respect that and always, you know, work with people for what they're most comfortable with. But by training our staff and also talking with families and increasing their capacity to connect via technology, we've increased that now. So more towards 55% it looks like of our calls are happening via video. We don't actually know, and that's a great question, are these happening on laptops or phones, but just from speaking with staff, the vast majority, I would say probably 90% are happening by smartphone.
Sure. And let's see, another question about the Community Action Network specifically. This person was interested in knowing about how community or patient input is solicited for the Community Action Network and how potentially providers are partnering with community members to help identify issues to target.
Sure. So our Community Action Network through Healthy Start, we're required to have 25% of our participants be either users of service or community members. But how we facilitate that is our home visitors actually recruit from clients that we serve for those who are interested in serving on our CAN. And how we prepare our clients for that participation is by training them in public speaking. What is the CAN? What is our approach? So that they have that level of comfort being in the same room with providers. Also, they are provided a gift card for their participation. You know, it's during the day, during our 9 to 5, we're paid for our work, so they are deserving of that same compensation. Also, we try to build their capacity. We've done a number of public speaking engagements where our clients have spoken on the CAN and their services to our city council person. We've done some Hill visits in Washington, D.C., where our CAN participants have spoken on the CAN and Healthy Start. So we're looking to not only have their input, but to also build their capacity and their skill set.
Great. Some other literature on home visiting programs has started to explore potentially the need for universal home visiting programs where not just low-resourced communities have access, but using it more as a preventative model, recognizing that everyone has the need for some extra support after a delivery. I'd be curious what your thoughts are, if that's something that you think New York City has a need for, or if the model that you have right now is really fulfilling the need that you see in New York City.
Absolutely. I think one of the main statistics that folks who are paying attention to maternal morbidity and mortality know for Black and African American women is that education and income level are not protective. And so there's a lot of, often cited statistics about about that. And so really, it's very clear that universal model is absolutely necessary. It's something that the City Department of Health and Mental Hygiene is working to expand one of their models to ultimately, hopefully, have universal home visiting one day. There's a huge need for it. And I think as our programs kind of evolve, that's one of the things that's very nimble around home visiting is when we apply for funding, it's generally for specific service areas. Some are very specific, many of our programs to actual zip code regions. And so that's come up recently. A lot of the home visiting programs in New York State participated in the Home Visiting Coordination Initiative and last year. And one of the findings in New York City from those conversations is those zip code restrictions and income and eligibility restrictions can be really restrictive. And so as we move forward and kind of reapply for funding, really broadening that is something that's incredibly important to account for what the data is showing us, for one, and then also just to be able to serve as many people as possible. So absolutely.
You'd also mentioned during your presentation how much of a challenge it is to conduct outreach, such a key part of your model while doing that virtually. So someone was curious to hear a little bit more about how you have been able to navigate that to do new outreach in such an exceptional environment.
So really and truly, it's all at the strength of our partnerships, our previous partnerships prior to COVID. We developed a very strong partnership with Empire Blue Cross Blue Shield, where they send us referrals for their prenatal patients. We're still receiving referrals from Jamaica Hospital. So we're really depending on our partners who are on the ground to connect us to patients. We're willing to do any virtual meetings. Our WIC sites are still sending referrals. So we've really been fortunate to build such strong partnerships that has continued throughout this pandemic.
Some other examples, back to partnerships, but some of the families that are most in need, families living in transitional housing or family residence shelters. And so kind of building upon those partnerships as well, having connections. And so we continue, one of the things we focus on, we're very data driven, is the diversity of referrals. So we don't really want 100% of referrals to come from a hospital where someone technically is already connected to a base of care, right? And so we look at what is that diversity of referrals? Are we getting folks from outside of the healthcare sector as well? And so we've been fairly successful. There was, of course, a dip in referrals in March, and then things kind of really ramped up once providers stabilized a bit. But of course, we also operate not just on referrals, and generally we do a fair amount of street outreach. We do outreach in clinics, walking down the street at train stations and things like that. And so that's definitely changed. I think one of the biggest testaments to successful programs is word of mouth as well. And so that's another big source of how people come to us is their mother, or their cousin, or their neighbor receives support from us, and we're happy with it. And so they connect new people to us as well. And so that diversity of referrals has changed in the past 6 months, but has stayed pretty steady and has allowed us to serve new people.
And also I'd like to mention, utilizing our existing outreach, we're doing PPE distribution through the COVID-free Queens initiative. So we are, we have our Healthy Start flyer. We are able to connect those who we meet in the community to some service.
Let's see, we also have a question. If, to add to the list of challenges that you've all had to adapt to and overcome, if there are any particular legislative barriers in the work that you're doing right now that you're trying to form some advocacy around.
Incredibly so. Off the top of my head, I think funding, without getting into too many details, out of necessity, completely understood, but incredibly challenging. Home visiting programs are very much struggling with threats and some actual funding cuts. And so, while the state economy is in crisis as well, legislatively, there's a lot to be done to make sure we're preserving baseline services. And it's really hard when you need to pick from apples to oranges of what to cut when everything is critical. When it comes to home visiting, though, really the long-term support that we provide, the stabilizing and resiliency building for families, as well as the multi-generational impact, it's absolutely critical to community health and wellness. And so legislatively speaking, I think we should all be, speaking up and talking to folks around preserving services. There have been programs across the state that have had to furlough staff and discontinue home visiting services. And so that's the first thing that comes to mind.
And then just looking at the home visiting model more generally, I'd be curious to hear your thoughts if you think there are other areas of public health that home visiting would be really well suited for, like diabetes management or older adult care, because it does seem like such a wonderful model and a lot of space to apply it to other areas of healthcare.
Absolutely, and I'd actually say that across the country, in terms of, I saw quickly someone also mentioned managed care, but there's been actually a lot more success outside of the maternal child health framework for establishing reimbursement mechanisms for proven community health worker outcomes. And so I think across the country, in New York State in some regards is moving in that direction. You know, community health workers and working with people from your own community and really task shifting things that don't need to be in the clinical setting into the community where we actually live has been proven to be incredibly effective. Looking at how to sustain those programs is very important. I think PHS, without calling them community health workers, it's not within the realm of home visiting, but just really connecting with people and assessing what their needs and interests are and connecting them to networks of resources to reduce, you know, the negative impacts of the social determinants of health. We're increasingly doing that type of work, meeting people where they're at. And so what it looks like, you know, a visit in home, or it looks like a virtual visit over a video or a phone, it's really just meeting people where they are and connecting them to all of the amazing resources that are actually in the world. And sometimes we have a hard time finding them.
All right, and one last question would be, you know, since so much of your model is also based on providing referrals for new parents, how have you been able to adapt when the referrals that you normally provide, maybe those services aren't currently being provided due to the pandemic, or they have a reduced capacity to accept referrals?
So we've had to shift, we've had to find other resources, but luckily a lot of mental health providers, a lot of providers have shifted to telehealth and virtual visits. Therapy, domestic violence support, they have shifted. And because of the pandemic, there has been an increase in food support in our community. So I can't say that we've really found that services have discontinued. We've found that there's been a shift and actually an increase in some.
All right, well, as we are closing in at the end of our time, I just want to thank Rachel, Poulette, and all of the attendees for joining this webinar. Just want to remind everyone that we will be sending out a recording of this webinar as well as the presenter slides later over email. If you want to keep tuned in on what other events and webinars we have, you can follow us on Twitter at NYSHealth or go to our website to sign up for our e-newsletters. So with that, thank you to our wonderful panelists and all our attendees, and have a great rest of your day.
Stay safe.
Take care.